we can look forward to as the healthcare providers in our communities and also in our healthcare industry. He grew up in Khayelitsha, in Cape Town, where he studied at the University of Cape Town, as I've indicated, and he completed his degree in distinctions in preclinical, clinical, and pharmaceutical examinations, which culminated in him getting the award for his first degree with first class honors in 2014. And he was awarded the Rhodes Scholarship, and after 2.5 years, at the age of 29, I was talking to my colleagues saying, at such a young age, he completed his Doctor of Philosophy at the University of Oxford in 2017, and he's got an MPS, as we indicated. That is fascinated by the intersection of healthcare, science, and business, and so he was inspired to evade a conventional career path and take the startup plunge with Cure Medical and Emergent Healthcare Group, the young companies that seek to transform healthcare in Southern Africa. Currently serves as the Chief Executive Officer of Cure Medical and also Chairman of EHCG. Dr. Mhlomi is also founder of the MH Foundation, an education non-profit organization that identifies and nurtures academically talented learners from socioeconomically underprivileged neighborhoods of South Africa. And hence we wanted him to come and talk to us and share his experiences and his vision about healthcare in empowering patients and redefining care delivery beyond hospital walls. So we're excited, Dr. Mhlomi, to have you in our midst and that you've accepted this invitation to share your thoughts with us and share what is it that we can learn from you, and that what is applicable in our settings in both the public sector and the private sector. And welcome to this webinar hosted by Clinics Health Group, a healthcare provider with lots of hospitals across Gauteng and in the Northwest. Thank you.
Thank you so much, Dr. Bila, for the invitation, and it's an absolute pleasure. When I watched the video that you had shared earlier on, I was reminded of my internship training days. I did my internship at Baragwanath Hospital, and so your hospital is sitting pretty much across. I've had the pleasure of working with a few doctors who currently practice there, but also through Hospital at Home, I've actually worked with a couple of your surgeons and physicians. And so I'm very excited to be having this conversation, with yourselves. I do think of it as a conversation, and again, very happy to be sharing with you, and look forward to engaging with you going forward. I just want to share my screen. If you could give me just 1 second. Okay, please confirm that you can see my screen. Let me try this again. Can you see my screen?
Yes, Doc.
Yes, you can see your screen. Sure.
Oops. Thank you. So, and just to confirm, you can see the full screen, because I think I've got another screen here.
Yes, it's now okay.
Okay,
Thank
fantastic.
you.
So thank you once again to everyone and for the invitation. I will walk you through what would probably be a new concept for some. I'll be building on a familiar concept for others. And I do hope that at least by the end of this conversation, we would all have walked away with having learned something new. Thank you once again as well for that very kind invitation. I get to work with a dynamic team at Cura Medical to talk and think about healthcare very, very differently, in a way that I think we should, in a way that in many ways challenges us as a people, as a society, as a healthcare community, to reshift our focus to what is best for patients, as well as what is best for our healthcare system more broadly if we are to survive. The first part of my slides is really just to introduce you a little bit to my company and what it is that we do. And then I want to talk about how we are leveraging, and rather how we are on a mission to empower patients by rethinking and redefining what healthcare looks like, particularly away from the traditional hospital walls. And I'll do so by telling you more about a technology-enabled hospital-at-home solution. I think the first part is, if you Google healthcare, both in South Africa and more globally, the one thing that will come across is our healthcare is failing. I think there's a growing burden of communicable and non-communicable disease. There are shrinking resources. I recently traveled to the US on a United States reverse trade mission. And, the challenges that we are facing here are frankly not unique. In fact, the challenges that we are all contending with, people experiencing the world over. And it's very easy, particularly when you look at South Africa, where you look at our healthcare system and say that it is failing. At Cura Medical, and I think this has always been an insight that I think I got from kind of growing up in Khayelitsha, and whenever you are surrounded by doom and gloom, if that becomes your focus, you often do not see a pathway out of it. This is one of the reasons why at Cura Medical, where everybody else sees healthcare or our healthcare system as failing, we actually see it as an opportunity to change it. And so that is the premise. And so change for many people tends to be very uncomfortable. And without a doubt, I will leave some people feeling a little bit uncomfortable. But I do hope that at the end of the session, we'll all see the vision and where it is that we are, the direction in which we are rowing together. I think the first thing I want to highlight is that the faces of healthcare is changing, right? If you look at just the representation within Cura Medical, you've got a young, diverse, globally best-in-class team to reimagine healthcare. The other thing that, COVID-19 taught us is that healthcare is everyone's business. And it's not only the preserve of those that have been educated, either in medical school or nursing school, etc. But I think once we start making healthcare everyone's problem, and if you look at some of my colleagues, some of them have a background in law and in tech and in machine learning and in commerce. I think once we become, once healthcare becomes everyone's problem, I think we then start heading towards getting much better solution rather than looking at it through a very particular or unique lens. But the other thing that is most exciting for me is that it's no longer the challenge that needs to be solved by the so-called old guard. We actually are seeing more and more young people who are thinking about what the future holds for them, and they want to reimagine and create a future that is fundamentally different than what we are seeing today. And so every time I check into work, I'm always inspired by this incredible team of people who have foregone traditional, paths, be it in tech or in law or in commerce, to focus their energies and attention in how we can get our healthcare system back on course. We are a we are a private company, so we are a for-profit, but we are a purpose-driven organization. And really our vision is pretty simple. And that is to keep pushing the boundaries of innovation, to demonstrate that exceptional quality healthcare and costs need not be mutually, exclusive, and that you can actually drive more accessible and affordable solution for everyone. And so we combine both technology as well as harnessing the best of our people to improve the well-being of others. We predate COVID in many ways, but when COVID hit us, it came in at a time when we were a lot more prepared to be able to support both our government as well as our patients, as well as other members in the private sector to improve clinical outcomes. For those of you that are encountering what I'm talking about for the first time, McKinsey & Company has been writing a lot about how healthcare is actually shifting away from traditional facilities into the at-home space. Some of you may have heard something called, virtual hospitals. And so I would encourage you to read more and more about that. It's taking off and becoming more commonplace, even in places like the UK, for example. And we're pioneering that within the African context. This is an interesting publication by McKinsey, which rather shows that about $265 billion worth of healthcare services that were previously reserved for in-facility care is actually moving, or rather would have moved, to the home by 2025. And that's really looking at the context of, the US. As Cura Medical, we are pioneering this change within the South Africa context and more broadly into the African context. And we are proud to have our solution being fully reimbursed by over 80% of the healthcare funders in the private sector to enable their members to benefit from this particular solution. But we are also proud to have more and more and a growing number of doctors and other healthcare professionals that are opting for hospital at home for their patients because it's producing some really, really great outcomes. And why it is important for us, so why do we need to change? Because healthcare is becoming increasingly unaffordable, right? And clinics, alongside many other traditional healthcare providers, are facing mounting pressures to reduce the cost while maintaining or improving quality as well as patient satisfaction. I mean, if you look at the average case cost, of a hospital stay, which was initially sitting at 42,000 rands and rising, makes this particular type of healthcare spend or utilization probably the most expensive. If you look at some of the CMS data, and this is 2019 data, which shows you the distribution of healthcare spend in the private sector, what you can appreciate here is that a significant proportion of healthcare spend and what is actually becoming a driver, of healthcare, what is actually becoming a significant driver of healthcare spend is sitting in the cost of hospitalization. GPs costs are sitting lower down, medical specialist costs, surgical, the medicine, etc. Kamo, please confirm that my slides are in fact moving.
Hi, Doc. Yes, they've been moving.
Fantastic. Thank you so much.
Sure.
The other thing that I think is important to highlight is that this problem, so despite healthcare or hospitalization itself being more expensive, we are seeing a growing number of cases that require hospitalization. And this is being driven by a number of factors. We are seeing an aging population, particularly amongst those in the private healthcare space, an increase in non-communicable diseases, as well as people trying to access medical aid benefits because they are downgrading from a medical aid perspective. But hospitals, and this is the biggest challenge, is that they're not just expensive, right? But they are also associated with unintended clinical consequences. And there are some studies that have shown that about 20% of elderly tend to suffer delirium. 1 in 3 patients will lose a functional status they'll never regain. And about 10% of them have a hospital-acquired condition or fall. And so if it is possible for us to create an alternative place of care for these patients might end up having a much better outcome. And this is not even considering the fact that hospitals are increasingly becoming, a place for antibiotic-resistant infections, and of course, the COVID-19 epidemic, as we started to see it, which drive significant morbidity and mortality. But what is most exciting for us is that, whilst previous research has shown that by merely shifting care of patients away from traditional brick and mortar facilities into the patient's home, you can lower costs. We are actually seeing a global trend where the home has been demonstrated to be a great setting for patient care and service delivery. We have shown that it is safe and that you've got better clinical outcomes and, frankly, a much better way of dealing with the healthcare crisis that we are seeing at the moment. I'm not sure whether some of you have already seen the news, but Discovery Momentum and Bonitas have recently announced that for 2024, we're expecting, a significant increase that ranges between, 6.9% right through to 9.6% across the schemes. And a big driver of this as well is how much we're spending in hospital spend. Now, I'm now going into a further case that I think I'm going to be able to kind of fly through very quickly. The first one is that part of why we are in this, we're facing this particular challenge is that we've got a hospice-centric model with rising costs and, lower system quality. We've got patients who are going into hospitals, and once they've been discharged, they are back in there within 30 days. Once they're inside hospitals, there's a duplication of some of the services, and some of you may be familiar. And then once they exit, we've got gaps in care delivery. The GP doesn't know that the patient has been admitted, and then they duplicate some of the work. There's poor medicine reconciliation. They are prescribing something else, the physician has prescribed something else, and the patient then, complicates as a result, and they're back in hospital. A majority of the patients following hospital discharge do not go back to see either their physician or their GP, and they are lost to follow up until they run into trouble. And then also the absence of post-discharge patient monitoring means that we miss opportunities to intervene before patients have significantly deteriorated. What that has done is that it's trapped us in a vicious cycle where you've got a decline in the quality of care and driving up the cost of care, which are becoming increasingly unsustainable and unaffordable for the patients whom we are trying to assist. And so enter the hospital at home model, which has ushered in the next frontier of healthcare. We are proud that as Cura Medical, we are leading the pack. And we like this particular model because we believe, much like Natalie Schibel in her publication, that this is probably the most innovative and pragmatic solution that will help mitigate against the spiraling cost, the massive increases in the number of patients that are requiring hospitalization, the spread of infectious disease, and of course, the protection of both our patients and staff. And so for some of you who are new to the concept, the definition of hospital at home is a service that involves the active treatment of patients by qualified healthcare professionals, so doctors, nurses, clinical associates, etc., in the patient's home of a condition that would otherwise require acute in-hospital care. And this is always for a very limited period. And so to further drive where we sit, if you look at a patient in terms of acuity, we've got patients who are so sick they require ICU, or you've got the traditional telemedicine where you've got relatively low acuity. We take patients who meet the specific criteria that can be treated at home that would ordinarily be admitted into general ward or subacute facilities. And so effectively what you have is a disruption of the traditional hospital entrance or admission model, where ordinarily you'd have a patient who goes to a GP or the ER, and then they subsequently get admitted to a hospital for a condition and then gets discharged. We see patients who get referred to us by GPs, by specialists from the ER, from urgent care centers, for conditions that would ordinarily require hospital admission. And instead, it's hospital avoidance, and these patients complete effectively their admission at home. And we've seen that these patients have done exceptionally well. Alternatively, if a patient has got a condition that does necessitate in-hospital admission, we facilitate a much earlier discharge, and effectively the patient continues their care and their treatment from the comfort and the dignity of their own home. Alternatively, we also have a transitional care program, which is really designed for patients who are at risk of hospital readmissions. They've completed the duration of their stay in hospital, but are at risk of coming back to hospital within the 30-day period. We then support these patients through a variety of interventions, again, from the comfort of their own home. And what this has enabled us to do is take what was an intractable readmission rate, reduce that, and produce additional clinical outcomes for patients as we help them navigate through the healthcare system. For those of you who may be interested from an academic perspective, there's actually a growing interest around hospital at home. I'd like to point you to three academics that are doing some interesting work in the space. In the US, there's a guy called David Levine, who's based in Massachusetts and Harvard, alongside Bruce Leff, who's a professor And some people say he's kind of the founder of like kind of home-based care and hospital at home in the UK, and he's based at Johns Hopkins. And from Oxford, you've got a professor, Sasha Shepherd, who often looks at this from the perspective of geriatrics patients in the UK. Further, for some of you again who are wondering what is happening in the context of the world, in the more global context, in the UK, actually hospital at home is driven by the NHS. They even actually have a society, and you're seeing a lot of the programs actually being available across Europe at the moment. In the US, we are seeing a growing number of healthcare systems beginning to offer hospital at home. In Australia, it's actually being driven at national and local government with really strong market expansion. And in similar emerging economies, for example, in India, we're seeing hospital at home providers serving millions of patients across the various cities. And so I hope you are at least persuaded that, one, we are not unique from a global standpoint in offering the solution, but also I think this is something that I do believe that the next decade within the healthcare space is actually has already been primed by this model called the hospital at home. And so how does this thing work? So we basically have got doctors who are seeing patients in their normal usual consultation. Let's talk a physician who needs to admit a patient for a procedure, let's say a cholecystectomy, into a hospital. Once the procedure has been done and the patient's risk has relatively dropped, that patient can be facilitated into the hospital at home program, where we then can continue to manage that patient with full monitoring from the comfort of their own home. Alternatively, you have instances where you've got a patient, and here again may be seen by a GP and has got pneumonia. And this patient can now be admitted directly into the hospital at home program, and that's where they complete their stay. We would then facilitate the care of these patients from the comfort of their own home. Alternatively, working closely with the funders, they help us identify patients who are at high risk of hospital readmission within 13 days using different predictive models, and those patients are usually admitted into our transitional care program, which is designed to prevent readmissions, and we have demonstrated very successfully our ability to do just that. And so what this has done is that we have shown in the South African market, and we've now begun to do our own expansion outside, that through very meticulous care coordination across the care continuum, with very clear clinical and evidence-based protocols, treating the right patient at the right place of care for the right duration can actually result in a reduction in the total cost of care that translates into scheme savings that can be passed on to the patients. And really, this is a system in which everyone wins. To speak more specifically again about what exactly is covered within the offering itself. So through our model, the patient's treating doctor, so there's no supersession, the patient's treating doctor continues to provide clinical oversight. So there's no expectation for the doctor to go into the patient's homes. We've got dedicated clinical teams, which includes doctors that carry out the patient's treating provider's care plan in the homes. So the doctor would write, I need bloods on day X, I need this, a physio to be done, I need, whatever is in the care plan, this particular medication. We've got dedicated teams who will ensure, much like we would in the traditional hospital, that care is delivered. The second part I want to highlight is that we provide real-time vital sign monitoring. So all our patients are monitored in real time. Unlike the hospital, where if a patient is in the general ward, they are monitored every 4 to 8 hours. We monitor our patients minute by minute. All this data is securely transmitted to a 24-hour clinical command center that is operated by doctors and clinical associates and nurses, where we do our data-driven clinical interventions. And the reason why this is important is because we've got early warning systems, and I'll speak about that later, that allows us to predict that the patient is going to run into trouble. And based on those predictions, we've got rapid response protocols that then allows us to dispatch any member of our network of emergency medical services providers to then escalate care if necessary. We facilitate the delivery and administration of medication, intravenous therapies, short-term oxygen. We partnered with major laboratories to make sure that not only are the lab tests done in the comfort of the patient's home, but they are expedited and that doctors are able to make timely decisions. For patients that require additional skilled nursing, whether it's for stoma care or for further or advanced wounds care is provided, and we bring all the allied healthcare services to the patient's home. And I think I've already spoken about the EMS. And really what we've done is taken all the essential elements of in-hospital care to the patient's home. The patient's original provider provides virtual clinical oversight, and so they continue to be involved in patient care. And as a result, they are reimbursed at the same rate as if they were seeing the patient in the hospital. And the reason why this is important is because the value they create for the patient and for the efficiency in the broader system necessitates that we are able to, reward them for the value that they're creating. But also we believe that doctors shouldn't be paid for their presence by the patient's bedside, but they should be paid for the clinical insight, whether that takes place by the patient's bedside or not. And so doctors can actually claim for their ongoing clinical oversight for the patients that they have referred. And so there's a very, very simple journey for the patient. So there's a prior consultation to make sure that the patient is examined and assessed that they be a suitable candidate. The most appropriate option is selected. We take care of the pre-authorization on behalf of the patient and the doctor. So the doctor's practice is not sitting on the line because we don't think that that's the best use of the doctor or the patient's time to try and get authorization. We handle this on their behalf. We then facilitate the admission and the onboarding of the patient from the comfort of home, and the patient can then continue to recover. Doctors are invited to join our growing network of providers that are referring at the moment, and it's completely free. So it's not a paid, network or database. We just interrogate, and make sure that they are registered and they've got an active registration on HPCSA. And then they consult, and it does not in any way, shape, or form disrupt their own clinical workflow. From a referral perspective, it's a simple one-page referral, and doctors can actually sign up, can actually also do this on our website through a very secure form where they can refer our patients. And this slide really just seeks to demonstrate that we actually look after a wide spectrum, or rather a broad spectrum of clinical conditions and diseases, from patients who got infections or community-acquired pneumonia, cellulitis, UTIs, etc., to patients who've got conditions that are frequently exacerbated, so your COPDs and your heart failures, etc., post-surgical patients, and the list is endless. But we do take any condition that is deemed appropriate by the referring doctor, provided that this would land up in the traditional brick and mortar facility. That being said, we know that this is not a condition, or rather this is not a service that is suitable for everyone, right? And so we do have a very clear exclusion as well as an administrative criteria for some of the patients. And all we want is to create a system where an appropriate patient gets appropriate care at the most appropriate level and location. And if you actually were to look at the hospital at home based on DRGs, and this is some data from the US, you actually see quite a bit of overlap with respect to case mix. Now I want to just go through very quickly through the technology. So all our patients are monitored with cutting edge technology. This is an example of one of our chest patch, one of our wearable technologies, which is the chest patch. It is waterproofed. It is FDA approved. It's CE marked and registered with the South African Health Products Regulatory Authority. With our technology, we are able to monitor a wide variety of parameters, from heart rate, respiratory rate, live ECG, oxygen saturations, glucose, blood pressure, you name it. We're also able to monitor posture. So we know when a patient is lying down, sitting up, standing up. We've got fall detection capabilities. So if a patient falls at home, we can we get an alert of what that looks like. And so for the first time, the treating provider is not blind to what is happening to the patient while they're at home. And again, we've got the privilege of being able to collect this information minute by minute. And therefore, we know what the patient's baseline is and how they deviate from that baseline. Providers are able to download our application from on Google and app stores, or can log on to our web application platform, where they are able to see their patients at any time from anywhere. So they can see what is happening with their patients. And depending on what it is, from radiology data to real-time vital sign data, laboratory information, and clinical notes. So we've designed the platform really to be a single source of truth, bringing efficiency into your patient care. So a lot of the technological products that are happening in the healthcare system are designed for billing, and they tend to be very cumbersome. We are focusing on making sure that in the traditional practitioner's routine, healthcare is becoming more and more efficient. And this is an example of our vital sign dashboard, where with early warning system capability that enables us to detect when patients run into trouble, and therefore get early intervention. And what you can appreciate here again is that you've got an early warning system. At any given time, we know when our patients are sitting at high risk and medium risk and high risk, as well as low risk, based on the clinical information that is coming in at any given time. Beyond that, because the patient data is coming in real time, this data is personalized and is not based on kind of different arbitrary thresholds that may not necessarily apply to that specific patient. We've designed it in a way that makes that note-taking, guided, so that it can reduce errors, which again tend to drive a lot of the medical and legal liability. Because of the data-driven trends that we've got, we are able to tell at any given time when a patient's condition is improving, is stable, or deteriorating, but also have created our platform in a way that allows us to collect, information that can be simply uploaded onto our platform, whether that is images of patients and how their cellulitis is tracking over time, or a doctor has made written notes that they want to capture and bring onto the system. And then lastly, we've organized, our notes in a way that is easily retrievable for them to be able to access. This is an example of what I think is, frankly, in many ways revolutionary for our healthcare system. So we are able to do 12-lead ECGs with interpretation and transmission in real time for doctors, for patients who are sitting in their home. Traditional practice dictates that these patients need to go to an in-facility, they need to receive in-facility care or go to the doctor's room before the doctor actually knows whether this person is having an MI or not, right? So what we've then done is to be able to decentralize that and bring it to where the patient is, but also make sure that the doctor has got access in a way that allows them to make that decision on behalf of their patient. For those that want to connect with their patients, we've got a video calling capability, which can be done on demand or scheduled. And while you're consulting with your patient, you are able to, visualize how they're doing from a physiological standpoint. I've already spoken about our 24-hour command center, where all of this data is coming through, and where we do our data-driven interventions. And so with respect to how we're doing at the moment, when we first started in 2018, we didn't think that, this would be possible. And I think for us, there have been two real achievements. The first one is actually creating a favorable reimbursement environment and having more schemes and doctors actually supporting this and choosing this for their members. And then, of course, demonstrating that we are able to deliver hospital-level care at home in a way that is safe for patients and preferred by patients. And today we do between 4,000 and 6,000 patient days a month. We look after, different, conditions. Patients love what we do. And we've demonstrated good success in being able to not just reduce the length of stay, but prevent morbidity and mortality, and also significantly reduce readmissions among these patients. But the outcomes that we've done are not unique to us. If you look at some of the published outcomes around hospital at home globally, they have demonstrated similar outstanding results independent of setting. More specifically, again, in our setting, we've got patients and their loved ones who love the work that we do. They comment about kind of the care and the friendliness that they receive from our people. As well as, most importantly, we've been able to enable families to be involved in the care of their loved ones at a time when they need it, the most. And so far, patients and of course, members of medical aids, and we want to extend this into the public sector, love the care that we provide. And lastly, and I think this is where I'm closing off, one of the things that we pride ourselves is actually working with different partners in taking patients off the grid. And here again is, identifying patients that would ordinarily be on long surgical lists, working with some of the players in the private sector to have those patients operated on privately, and then continuing their care and their recovery in their home. In so doing, you actually are bringing efficiency, into the space, and patients who would have ordinarily had to wait, for a very, very long time, purely because of costs or inefficiencies within the public sector, can now receive life-changing surgery. And so we are growing, and we are proud that most recently we've actually just opened up and expanded our services in KZN, and we will continue to grow within the different facilities. And we believe that using this particular model with proven clinical outcomes and potentially a solution for our healthcare system, we can work together with clinics and yourselves in driving a healthier continent. Thank you so much for your attention. And at this point, I welcome any questions that you might have. I'm not sure if anyone is speaking, but
Yeah, no, we are here trying to unmute myself.
I've
been challenges in unmuting myself. Thank you very much. I think Kamo has taken away my ability to unmute myself or even to start the video. If you can make the co-host Kamo, please. Thank you very much, Dr. Mhlomi. It's been quite an innovative presentation about what care you're providing and what are the possibilities in terms of what you're doing. Something, I was talking to someone, he was saying that this might require some business engineering, looking into the future. I don't know, in terms of what you're saying, are you predicting that the traditional way of doing medicine in the various healthcare groups might have to look at the possibilities of maybe adopting some of the proposals that you're making? Can you hear me?
Yes.
Did you get the question?
Yes, I did. Sorry, I was struggling to unmute as well. The simple answer is yes, right? I think as an aspiring healthcare futurist, I do think that, the future of healthcare is that you're probably going to have, centers of clinical excellence, ICU facilities, ERs, and theaters, and a majority of the patients are going to be treated at home. And I think that as clinics as a leading healthcare provider in the space needs to think about that, right? For a number of reasons. I think the first one is that we are beginning to see the shift from a provider perspective. For example, it is common cause that Life Healthcare is an investor in our company, precisely for this reason. We know that MediClinic has now started and launched a care at home program to drive their strategy on this particular front. And then lastly, we are starting to see from a funder's perspective where for a subset of clinical conditions, hospital at home, Discovery announced a few days ago that for a subset of conditions, hospital at home is actually going to become a DSP, right? Starting from January of next year. And so what we're starting to see again is that there definitely is a shift. And so if I was sitting in the hospital provider space and I was clinics, I would want to find out, Dr. Bila, how do I organize an urgent meeting with myself about how do we then potentially work together, around how do we work together around the delivery of care for these patients as far as your business is concerned. Because I think all patients are going to need, I think all patients, you can't replace hospitals, but I do think there's a way in which you can make that entire model a lot more efficient.
Okay. Yeah, well, I think this space, maybe just to clarify, this space is open for all practitioners, public, private, so it's not necessarily a platform for us to look at. But I think just to share ideas, share thoughts, and as you said, you're being futuristic and you're looking at future developments and trends, and what are the possibilities of adopting some of these trends. I mean, like telemedicine, you've spoken about it, that everyone should be thinking about telemedicine, and you seem to be looking at perhaps adopting it, the use of technology, monitoring patients minute by minute at home. There's a question that let me take this one first, just maybe dispose of it quickly. It's about how to engage with other colleagues. This is from Linda Mabas, who says, I've actually previously contacted your company about pediatric application. Have you since acquired FDA approval and sub-approval in the pediatric space?
So still ongoing. So the only reason we're doing 18 and above at the moment is purely because of the tech being approved to be used in adults patients. It's a new technology. So as soon as it's approved by the FDA for use in pediatric populations, we'll be happy to work with Dr. Lillian in how we could provide these services for the pediatric patients.
Okay. Well, in your presentation, you looked at in the clinical care pathway, post-discharge going home. There's one area that you spoke about, reducing the readmission rate, the 30-day readmission rate, which medical aid is actually looking at. How is that space looking, and how has been your response, and what impact have you had when we're looking at various post-discharge cases across the healthcare spectrum, not one particular healthcare group?
Absolutely. So that has been across the board, very successful, probably one of the most successful programs. So working with the schemes, they identify patients who are at high risk of being readmitted. And there's a suite of interventions that we do in the patient's home. So, for example, we've picked up that patients go back due to medication errors. When they get discharged from hospitals, not enough TTOs. The third part is these patients are discharged from hospital with ongoing infections, for example, undiagnosed UTIs that are brewing in the background, and then day 16, these patients would ordinarily go back. So we screen, identify, and manage these patients actively. Right through to cardiac patients who are at particular risk of going back, we actively manage those, and we make sure that the patient actually go back and see those patients. So we've got a suite of interventions that are designed to prevent these patients from going back. And actually, these are based on clinical evidence. And we've been able to, in a very short period, demonstrate a reduction in the number of cases that actually do go back, to hospital. Naturally, some of the cases are unavoidable, whether this is a kind of a natural progression of the disease. While we try and actively manage that in the home, some of those do require, ongoing care, or some patients require revision of surgeries, post-discharge, etc. But it's one of the things that's actually happening very, very well and producing excellent outcomes in the post-discharge space.
Okay. And just to close off this discussion. And when you look at these cases, do you find that there's been sufficient patient education upon discharge, or is that something that is lacking, or in terms of the doctors writing discharges, summarize patients, and also make it easy for patients to know what to do when they get home?
So absolutely not. We find that we're really finding that for a lot of patients, they go back to hospital for things that I do think that, if properly managed in the hospital space, including education, their readmission rates would be low. Most of the patients don't even know about the conditions that they are, that they're suffering from, right? Some of them even think that the readmission is part of the course of the disease. So poorly controlled diabetes is part of the condition, right? They don't know what it means in an end. And the value of our solution is the ability to sit with the patient and their families to actually drive patient education. And even that alone as a single intervention would make a massive, massive difference in preventing readmissions for these patients. And that's one of the things that we are strengthening around patient education. The other beautiful thing for us about treating patients at home is that the power dynamic between provider and patient shifts towards the patient, right? The patient invites you as a guest into their home, and you're able to manage and actually bring in their families here, which is in sharp contrast to what you ordinarily get in the hospital, which everyone is really busy. You've got numerous other cases you need to get to as a treating provider, with very little time to actually sit and provide education to the patients. And so I do think that we're seeing a lot of gaps. There are no discharge summaries, Dr. Bila, which again is really, really unfortunate. Patients are discharged with half TTOs for course of treatment that they need to get. There is poor follow-up. So sometimes doctors see patients when they are back and readmitted into a hospital. No one is seeing patients in rooms. There's no communication between GPs and the admitting providers, and therefore there are gaps that the GPs refer patients for pneumonia. Patients come up with hip replacements, and I think there are missed opportunities around care coordination, and our role closes that gap. It allows these two providers to speak. We manage and assist the patient, we empower them, and we assist them in navigating that course. And I think that's probably one of the things that has assisted us in having such a dramatic impact for these patients in such a short period.
Yeah, should not be belaboring the point, but you give feedback to the providers once you identify these gaps. I mean, say, Dr. X, you discharge this patient, and these are the following areas of concern that you've identified.
So, to be honest with you on this, we could do better with respect to provider engagement. I think the biggest challenge for us is that often the email address that some providers list tend to be the billing companies' emails addresses, and often they don't necessarily see, right? And so as we've got doctors, so part of the reasons why we invite doctors to sign up on our website is so that we can have the most accurate email address for ease of communication. But when we actually just look at purely the kind of the database that is available, we often find that the recipient, so even when you do engage or when you do write, and sometimes even when you call, you get, the numbers end up with the billing company instead of the provider. And so I do think that we could work better with providers in enhancing the communication.
Okay. Thanks for that feedback. We're taking note. Prime Hipeji wants to know, are the home circumstances assessed beforehand as well as the family dynamics?
No, absolutely. So remember, we also do this, we don't force this with patients consent, right? As far as this is concerned. And the other thing that I think is always important to recognize is that patients don't live in hospitals. And what we've seen, and studies have shown this, that the sooner we treat patients in environments in which they're going to exist and live and manage their conditions, often the better. A simple example that we've seen is that with insulin being delivered to patients' homes, for example, we find that patients actually don't recycle their stock. They just take whatever comes in, expired or not, but because this was stock that came in first, that is what they'll use. And they will be adherent to that insulin, even though it has expired. And so what this has enabled us to do is to get into patients' homes and say, look, show us the medication that you take. Then you find out it's expired, they're taking their brother's medication, their neighbors, whatever's growing in the garden. And this becomes a teaching opportunity for us to actually work with the patient in putting them on a much better course, right? And so just coming back again to this point, is that the idea here for us is not to manage patients whose home environment is not suitable. I think if hospital for that particular patient is best, we want them to be in hospital. But the same must be true, that if you've got patients where home is best, we've created an alternative where that kind of care can and should be delivered.
Yeah. When you speak about stock, remember, I won't discuss this quite a lot, but I ended up going to a hostel many years ago in Stillbal, and we found a patient on renal dialysis with boxes and boxes of solutions and syringes that they were keeping in the hostel. Because we were staying in the hostel and we were renal dialysis patients, so they were getting medication solutions delivered directly to their homes in the hostel. Yeah, next question is about crime now. I didn't think that would be discussed in this. Are you not worried about crime happening to healthcare professionals when they go to see patients at their homes?
So we accepted our first patient in 2020. We are in different regions, in Soweto, in Tata, and we have gone into, in parts of Gqeberha. I think what helps is that when you work with people who come from the communities where the patients reside, and they are familiar with those territories, they navigate those easily. But the safety of our staff is, of course, very important. So all our staff are being tracked. They've got emergency emergency response mechanism. We actually have a dedicated provider whose role is to respond in any emergency settings. But we feel strongly that often that's a reactionary approach. If an incident happens, we know that we can get them out of there. But it's important for me to speak about in practice. We actually have not seen this. We haven't seen attacks on our people. We haven't seen hijackings, and I hope we don't see it. And I think what has been really, really helpful is being able to get people who actually are familiar with those spaces. But the other thing is that we've also had clinical personnel who from Afrikaans background in Pretoria that have gone to see patients in some of our townships. And again, we actually haven't seen those attacks. And so I do think that the risk is there. I think we've tried as a business to mitigate that risk against our thing, but in practice and in reality, we haven't seen that materialize, and I hope it doesn't.
Moving from crime to ESCOM, so that you're the fourth industrial revolution technology. With the pages that you provide, are they internet-based? What happens if there's load shedding? Are you still able to monitor these patients minute by minute?
The beautiful thing about innovating in South Africa makes it easy for us to export our technology, because we've had to innovate in one of the most difficult places to innovate. So all our technologies are battery operated. And because we know, so they collect information and transmit them via Bluetooth. And because we know that not everybody has got a smartphone that is intelligent, we actually give patients smartphones on loan that are locked for this particular purpose, and they are fully internet enabled. So patients don't have to worry about their data. We also have a backup battery power bank that can do up to 8 charges, for patients. And lastly, the SIM card itself is dual internet enabled. It's dual SIM card enabled to ensure that we, at any given time, we always find the best networks. Also, it's common cause that we partnered with MTN precisely for making sure that the transmission of our data is enhanced for these patients, so that care is not compromised. So, as I mentioned, we've been doing this since 2020, and so we've had to innovate for ESCOM. We've had to innovate for expensive data. We've had to innovate for patients who may not necessarily be able to afford, sophisticated and expensive technology, and we've been able to make it accessible and affordable for them.
Great, yeah, you have to innovate, and you've got to be agile in your plans also. Will the homeowners? This is now Dawood Pierre wants to know. Will the homeowners be reimbursed for use of of their homes? Will nurses be stationed 24 hours? How does it work?
No, these are patients who are being treated in whatever place or space they call home. And so we bringing in the clinical solutions from the convenience and the dignity of your own homes. And so there is no, I guess, additional fee that is being paid. So it's not an Airbnb model where we kind of rent out people's homes to treat others. That may very well be an interesting model. The idea is to go into whatever the patient calls home and try and provide care in a way that is tailored for that specific patient, and of course that then resulting in better outcomes. As I mentioned earlier on, our wishes are that the patients who access our service the savings that the schemes get to enjoy are then passed on to those members, because it's a lot more cost-efficient model.
Okay. Yeah. Langa Mensa, you are interrupting us now. You just mute him. Okay, there's another question that I almost missed there. Excellent presentation. I think that's not the one. There's one that I missed. The current program of healthcare linked to specific network doctors is excellent. Service-centered all sites. I think the comment where they are operational or linked to, are they operational? Are they linked to any local hospital or clinic?
No, sir. They are not. Every doctor, so if there are doctors who are here, they would like to work with us and use our solution, they go on our website, and the doctors section sign up, and so you don't need to be affiliated with any particular hospital.
So you do work with specialists and GPs or specialists general?
No, so we work with
specialist knows about you and just say, I've seen this patient, and rather than seeing this patient going to the hospital, they bring them to you. Or how does it work?
So absolutely. So we work with GPs and specialists. One of the things that I always say is that if you look at our public hospitals are actually run in many ways by medical officers and family physicians, etc. But for some reason, when you look at the private healthcare space, you've got a lot of physicians and doctors. GPs are kind of relegated to treating colds and flus when they've got the capability to be able to look after patients with more complex, presentations and diseases. It's just that you've got a system that doesn't enable them. We have fixed that. So doctors can now, GPs, if they've got a patient with a pneumonia, they can actually, actually admit patients into, their care in the communities in which they provide, and they get reimbursed, for it, right? And that for me is important. We work with physicians that opt to look after these patients, at home as well. So it's really open for everyone. We even have surgeons that refer patients to us after they've done their procedure, particularly because of the risk often associated with readmission and wanting to make sure that these patients actually do well in the home after they've been discharged.
Okay. Any due diligence on how medical aid risk insurance may impact the service that you provide?
I need a bit more clarity on that question.
Yeah, but maybe they are just worried that maybe if you are taking any risks when you see patients and maybe the medical aid may not pay you for that. If you had any challenges with that perhaps you taking the risk on yourself.
No, not that has not been a problem. If anything, we've actually found hospital providers, we found funders being exceptionally collaborative. And I think the reason why is because I think that, when you see a model that creates true value, and one that will allow us to address, I guess, in many ways, the healthcare system more broadly, guys tend to collaborate a bit better. So we haven't had to take any risk, and we haven't had issues with being paid by funders. If anything, we've seen the opposite. We've been embraced, we've been supported by the various healthcare stakeholders, including patients.
Okay. Yeah, yes, this one is quite a loaded. Bongani Kulu is a surgeon. So this is an excellent presentation. The model is applicable to the affluent population. But when you work in the public service, patients are brought in and kept longer in hospital for social or poverty-related reasons. And if a clinician tries to discharge the patient, the family complaints, and it's lodged by the family. Clinician faces onerous disciplinary hearing process by management and the health ombud. Do you have a role to play there? Because I see that you are more profit-driven, if I may say so. And then,
so thank you.
Do you have any presence in the public sector, in public service? And I'm saying this because I'm looking at the NHI now coming.
Absolutely.
Be able to interface.
Absolutely. I think if there's one business that is uniquely positioned to support the efforts of, I think, the NHI and what is envisioned in it, I think it is us. Secondly, I think what's important to highlight is that our role is to, we believe in value-based care, and part of how you assess value is also looking at quality. And then lastly, I'm from Khayelitsha. If I can't produce a technology and a solution that my mother, who is in Khayelitsha, can benefit from, this would be completely useless. Frankly, we are not driven in any way, purely by profits. We only look at a for-profit model purely because a business like this needs to be made sustainable, right? We are, and us not being at the moment within the public sector isn't because we haven't engaged. We actually have made attempts at engaging and working with government. We know that we'll need a more nuanced solution that is responsive to the various, needs within the various provinces. And actually, we are going into a meeting on the 2nd of October to meet with the Western Cape Department of Health to start actually looking at how this model can potentially be rolled out within that setting. I have made same extensions to Gauteng. I've made the same in the Eastern Cape, etc. But again, it isn't because we haven't made any effort. But I imagine when you are dealing with multiple priorities and you've got competing priorities, you need to decide as government where to focus. But I do think that there's a real big opportunity, and the patient we want to impact is the public sector patient. And I think that's where we headed.
Yeah, I think that I met some people a few years back when I was still in the public service. We're looking at this model, say if you've got a patient who needs to be discharged home, you know that they need something like Dr. Kudu says, they need to continuous care at home, but like patients with with surgical procedures, so that maybe they are on the pouch that they need to be wood care at home, and so somebody needs to look after them. You find that there isn't anybody to look after them, and I think the public service may benefit a lot from such interventions also.
No, absolutely.
Yeah. So someone says that you're looking at the model and I think the discussions and the gaps identified. They're saying that Dr. Syed said that why not improve the focus on improving the operation between the doctors and specialists and the patient. So for improving patient education also. But you did allude to the fact that it's something that you may.
It is a focus.
That is an area for improvement in your model.
Absolutely.
That communication between doctors, referring doctors and patients or post-discharge.
Absolutely.
Yeah. Yeah, I think maybe to close off, Dr. Pierre wants to know, which you've answered, I think, are non-medical aid patients eligible for your services?
Yes, we actually are seeing quite a number of non-medical patients, because remember for some of these patients, the alternative for those that don't want to be in the public sector are having to pay massive bill, right? But depending on the clinical conditions, for example, the savings for us is anything between 30 right up to sometimes 85% compared to a traditional hospital stay. And we've actually seen patients and their families accessing this on a private basis. And we're probably going to see those kind of growing numbers, which is one of the reasons why we want to be able to close our conversations with the public sector so that patients are not having to do that to access our solutions. But yes, we have made provisions and patients are using it.
Yeah, okay. Maybe last question for myself. You said you're going to make people uncomfortable. So trying to check also if I can make you a little bit uncomfortable. Are you seeing yourself as a competitor to the healthcare providers, or are they seeing you as a competitor?
Not at all.
And if not, what are the areas of collaboration, or are you see areas where there's stiff competition and animosity between you and the healthcare providers, hospital healthcare groups?
Sure, no, absolutely. So one is we don't see ourselves as competitors, and I don't think that healthcare providers have seen us as that. If anything, we've seen them embracing this. And the only competitor, or rather the only thing we're all trying to solve for here is a healthcare system that is in a lot of trouble. And so I think everyone is kind of trying to work together to find out how do we collaborate to make sure that this healthcare system survives. And so we've seen, again, a very good working relationships. It is impossible to replace hospitals. That's not our goal, right? But we also know that there are a limited number of hospitals, there are a limited number of beds, there's a growing demand, and we need to be able to provide an alternative solution to be able to care for those patients. And that means making sure that the right patient, if a patient needs to be in a hospital, they need to be in a hospital. If they need to be at home, they need to be at home. But the inefficiencies where a patient is in hospital for longer than they need to be, or in hospital for the wrong reasons, is actually doing a disservice to the entire healthcare system. And I think that's what we're trying to see. And we've been very, very proud of healthcare groups who've seen this and have found ways to actually collaborate with us. And we are collaborating with more hospital providers, across the spectrum. And we're probably seeing more of that, of those kind of relationships growing, because if we don't, our healthcare system is going to pay the price.
Sure. Thank you very much. I saw there was a hand, Rajesh Mistry. I don't know if your hand was up, but I see you've lowered your hand. If you want to speak, please indicate, maybe unmute yourself. Rajesh, yeah, go ahead, just unmute yourself, or come on, unmute Rajesh. Go ahead. Yes, Rajesh, see your hand is, unmute yourself, please.
I think I might need to unmute.
Yeah, I'm trying to unmute him. I can't. I don't know if can you unmute him?
Yeah, I also tried to unmute him, but it doesn't seem like he wants to unmute himself.
It's a mistake. Okay. Yeah, maybe someone is playing around with it. Okay, no, thank you very much. There's last comment as I said in the private healthcare sector in the public service. Are you seeing opportunity? I know we spoke about NHI, but also there are some students who are sent out to work in the public in primary healthcare, linked to other university colleges, nursing colleges, or nursing university programs. Are you keen to collaborate with such?
Yes, and yes. I think there's something brewing in some of the universities at the moment, because we're talking about training healthcare professionals for the future. This becomes the fundamental basis of that particular learning. We subscribe to community-oriented primary healthcare, and so I think primary care, and so I think there's opportunity for us on that front. And I definitely do invite people who would like to see how they can collaborate with us to, drop me an email, connect with me on LinkedIn, go into our website, and we're open, because I think, again, our goal is simple. We've got a healthcare to fix, and we will work with whoever shares that vision.
Okay. Thank you very much. Thank you. We've come to the end of our discussion. As we said, a conversation, worth a conversation to have about casting our eyes into the future of a healthcare delivery system in our country. And I just want to thank you very much for taking your time and availing yourself for this discussion and the presentation. I'm sure colleagues have gained quite a lot from this insight that you've provided, looking at the walls beyond the hospital walls. And I want to thank Professor Morgan Chetty for also linking me up with you, so that at least I can gain such information from you. I think primarily we're looking at patient safety That was the main focus of our discussion, because I think that's what the primary focus of your organization is in. So thank you very much, and wishing all the best with all your colleagues in what you're doing. And on behalf of Clinics Health Group, we just want to say thank you for taking this opportunity to speak to us. And to thank all the other colleagues who logged in, quite a number of more than 200 people logged in here today, 240 at some stage who listened to this presentation. I'm sure they would want to contact you beyond this presentation. And to thank Kamo also in the background for making sure that we have these sessions every week, and the team from marketing within Clinics Health Group. Thank you very much, and a good night to you.
Thank you.
Thank you.